Let's talk about one of the most fascinating and honestly, most frequently missed syndromes in all of medicine, catatonia. We're going to break down this really complex condition, starting right at the patient's bedside and going all the way to the underlying causes so you can feel totally confident when you see it.
Okay, so picture this. You're called to a patient's room. They're just lying there, totally still, not saying a word. Their eyes are wide open, but it's like they're looking right through you, not responding to anything. Your mind is probably racing with possibilities, right? Well, catatonia needs to be right at the top of that list. Let's figure out why.
So here's our game plan. We'll start with what the patient actually looks like. Then we'll dive into the really unique physical exam signs that basically clinch the diagnosis. We'll talk about the two very different faces of catatonia, look at all the different things that can cause it, and then, most importantly, figure out how to treat it. All right, so back to our patient. They're motionless, staring up at the ceiling. They haven't moved or made a sound in hours. You might even notice something subtle, like saliva pooling in their mouth because they aren't swallowing. This profound lack of movement, this psychomotor disturbance, that's our first huge clue. Now for the fun part, decoding the signs. With a patient like this, the physical exam is everything. Seriously, you're not going to find the answer in a blood test or a CT scan. The diagnosis is made right there, at the bedside, with your own hands and eyes, by finding some classic, almost bizarre, physical signs.
So the absolute hallmark sign of catatonia is something called waxy flexibility, or if you want to be fancy, seria flexibilitas. It's a feeling. When you gently move the patient's arm, you feel this smooth, even resistance through the whole range of motion. The classic analogy is perfect. It literally feels like you're bending a soft wax candle. Once you feel it, you'll never forget it.
And here's a really cool bedside test that shows this perfectly, the psychological pillow. So the patient's lying flat, you gently lift their head up off the pillow, and then you just pull the pillow away. And their head just stays there. It just hangs in midair, held up by their neck muscles, exactly as if the pillow were still there. It is one of the most striking things you'll ever see. And it's not just waxy flexibility. You can see a whole constellation of other signs. There's posturing, where they hold these weird poses for ages. Then there's negativism, the stubborn, automatic resistance to anything you ask them to do. And you can see the total opposite, automatic obedience, where they follow commands like a robot. And finally, you get the echo signs, echolalia, where they repeat your words, and echopraxia, where they copy your movements. It's all part of this very strange psychomotor state.
Okay, this next part is absolutely crucial. You have to understand that catatonia isn't just one thing. We tend to picture that frozen patient, right? But it actually shows up in two completely opposite ways.
So on one hand, you have stuporous catatonia. That's the classic version we've been talking about, the most common one. The big three signs are immobility, waxy flexibility, and mutism. But then, on the other end of the spectrum, you have excited catatonia. This looks completely different. It's this bizarre, frenzied hyperactivity, but with no purpose. The patients are agitated, restless, and just seem totally sealed off from reality.
And that excited form, that is a true medical emergency. If you don't treat it, it can spiral into something called Stauder's lethal catatonia. All that constant hyperactivity causes their body to go into overdrive. They get a high fever, a racing heart, their blood pressure goes haywire. This can kill, so you have to recognize it and act fast.
Okay, let's bust a huge myth. For a long time, people thought catatonia was just a part of schizophrenia. That is completely wrong. Catatonia is a syndrome, not a specific disease. Think of it like a final common pathway that can be triggered by a whole bunch of different things, psychiatric, medical, you name it. Now, most of the time, the cause is psychiatric. Things like schizophrenia, bipolar disorder, especially during a manic episode, and even severe depression. The thinking is that these conditions mess with the brain's neurotransmitters, particularly GABA and glutamate, and that imbalance can kind of get the brain's motor circuits stuck. But you always have to think about medications. High-potency antipsychotics are a classic trigger. Here's a great clinical pearl. The drug disulfiram can cause catatonia, but it can happen months after the patient starts taking it, so it's really easy to miss that connection. And don't forget withdrawal. Suddenly stopping benzodiazepines can definitely throw someone into a catatonic state. And this is why you can never just assume catatonia is psychiatric without doing a full medical workup. It can be the first sign of something really bad. We're talking about brain infections like herpes encephalitis, autoimmune conditions, strokes, or even severe metabolic problems. Catatonia is a huge red flag that something serious might be going on underneath.
All right, so you've done your exam and you're pretty sure you're dealing with catatonia. What's the next step? Well, now you have to be a good detective and think, what else could this be? This differential diagnosis is absolutely critical.
If your patient is on an antipsychotic, there is one question that trumps everything else. Is this catatonia, or is this the life-threatening emergency known as neuroleptic malignant syndrome, or NMS? They can look similar, but NMS is a whole different beast that can kill if you don't catch it.
So how do you tell them apart? Again, it's all in the physical exam. The rigidity in catatonia is that smooth, waxy feeling. In NMS, it's a severe lead pipe or cogwheel rigidity. It just feels different. Plus, with catatonia, you have that posturing where the limb stays where you put it. You don't see that in NMS. NMS usually comes with tremors and major vital sign instability, which aren't the main features of catatonia.
And what about differentiating it from other causes of stupor, like from a metabolic issue? Well, it all comes down to one thing: alertness. A patient in a catatonic stupor is actually awake. Their lights are on. It's a motor problem, not a consciousness problem. In fact, they might even actively resist you trying to open their eyes. That's totally different from, say, a coma, where the patient's level of consciousness is truly down.
Okay, let's bring it all home. We figured out what it is, we've ruled out the mimics. Now what are we going to do about it? Let's talk treatment and then do a quick high-yield review.
For stuporous catatonia, we start with something called the lorazepam challenge. You give an IV dose of a benzodiazepine, and often it will temporarily break the catatonia. It's pretty amazing to see, and it helps confirm the diagnosis. But for a definitive cure, electroconvulsive therapy, ECT, is really the gold standard. And while you're doing all that, you can't forget basic supportive care. These patients are at huge risk for dehydration, blood clots, and pneumonia.
Now, for excited catatonia, things are a bit trickier. The immediate goal is just to get the agitation under control, usually with high doses of benzodiazepines. Once things are calmer, you can slowly start introducing antipsychotics to treat the underlying psychosis. It's a real balancing act. And to help you remember all this for your exams or for the wards, here's a great little mnemonic: I'm stuck. It covers all the key points: immobility, mutism, stupor while alert, the two forms, the diverse underlying causes, catatoplexy, that's our waxy flexibility, and the key treatments, lorazepam and ECT. Perfect summary.
I want to leave you with this quote because it's so important. Your patient might look like they're totally gone, completely disconnected, but they're probably aware of everything happening around them. When they get better, they might remember every single thing that was said and done in their room. It's a powerful reminder to always be professional and to talk to your patient, even if they can't talk back.
So let's end with this question. Catatonia is the great pretender. It can look like so many other things, and it can be caused by so many different conditions. So I'll ask you, could there be a patient on your service right now whose strange behavior is actually a case of catatonia, just waiting for someone like you to recognize it?